When a woman starts her stimulation protocol for an IVF or an IUI cycle, she is recommended injections. Now there are plethora of options available. You have urinary injections, you have recombinant injections, you have a FSH injection, you have a LH injection, and you have a combination of FSH and LH called HMG injections. So who do we choose, what do we choose, and how do we select what is to be given to whom? See, one thing is clear. Women need to be given stimulants such as FSH or LH to grow their follicles if you are wanting to grow more than one follicle. Now let's go back to what happens in nature. The brain releases both FSH and LH, usually in the ratio of 2:1, FSH in higher quantities, LH in lesser quantities, and these two hormones go and work on the ovaries to grow one follicle every month. If I were to get in and put more FSH and more LH in the system, then we can expect more than one follicle to grow. Simple. So ideally, all our women should be given a combination of FSH and LH in 2:1 ratio, because that's what is fundamentally happening in nature. But things are not so simple. How do we get this FSH and LH molecule? We have to make them in the lab, or we have to get it from the urine of postmenopausal women. Now FSH LH hormones are synthesized in the brain. If you don't use them, they are leaked in the urine, and if you collect the urine of menopausal women who do not grow their eggs anymore and they have lots of FSH and LH in their urine, then you can distill that and use it to inject other women. This is what is known as a urinary gonadotropin, or a HMG, or a human menopausal gonadotropin injection. They contain both FSH and LH, but in a ratio of 1:1. This urinary injection is a good product to use, and they work fine for most of our women. The only challenge is, because it's a distilled product and because it is collected in the lab, there are errors of distillation. So you cannot always get a very pure product. In some months, in some batches we call them, the product is extremely good, works like a beautiful thing. In other months, for some problem in the distillation process, it does not work at all. So the reliability factor goes for a toss. So this is as regards the HMG. What about recombinant injections? These are actually synthesized in the lab through genetic technology. Now, these are fundamentally designed to be extremely pure products. But the whole process of making and synthesizing these injections and the patents that are associated with this process makes them inherently expensive. So you have two issues. HMG, which is cheaper but may not work all the time, and a recombinant, which is expensive, is purer and possibly works all the time. We always need to balance the both factors and take a call. I would personally prefer all our women to be injected with purer form, that is a recombinant FSH and LH combination, provided the costs could be mitigated or managed to a certain extent. Sometimes we start them on FSH or recombinant injections and then combine a little bit of HMG to keep the costs low. Sometimes we do not give them the FSH injections, we start them in HMG in case we know that this batch has been doing well in the previous patients. At a fundamental level, both of them do the same work and they do not make much of a difference to the outcome.